Thanks very much, Christy, and thanks to the Centre for the invitation. I've basically been back in Australia since May of last year, after having spent some 17 years out of the country, and this is just I suppose this is just my credentials for speaking today in terms of the trajectory that I've done. And there's lots of things that I'd sort of be very keen to talk about. So I'm going to try very hard to restrict myself to about 35 minutes at the most, so that we have a solid discussion time. And I also want to kind of try and mainly present the sort of broad narrative sweep with some little deeper dives every so often. The place I think I'll start is actually just to recall really the late 1990s and 2001 and the UN General Assembly Special Session on AIDS. And so this was the first time that the UN General Assembly had a health-related sort of discussion. Most of its special sessions, and they're designated things that the General Assembly has, most of their special sessions had been basically security and geopolitics related things. Now, the main thing I want to recollect about that meeting in 2001 is that, of course, the targets that were adopted then were all HIV prevention related. There were no treatment targets, because at that point, and this is something I think sort of sometimes people have difficulty remembering back to, that in 2001 it was still the case that the major development assistance donors were determined that there couldn't be funding for HIV treatment in resource-constrained countries, that was throwing good money after bad. And of course, as we recall Andrew Natsios, when he was head of USAID, saying, well, how could people who didn't have watches tell the time to be able to take these complicated medications that they had to take on a strict schedule? So that was, and I dug up Natsios's quote, and it's interesting to look at that again at the time. But by that stage, there had already been an access program that UNAIDS had sponsored with some support from the World Health Organization, which had basically proved the efficacy of HIV treatments in resource-constrained settings, so that actually the notion that they wouldn't be able to work, they wouldn't be able to roll out, had already really been disproved by the 2001 period. But at that stage, there was still that reluctance to take that step for something that much later, for example, the UK Parliament had a report really just a few years ago on the treatment time bomb, and there was a notion that this treatment expectations that have been created in developing countries had created a time bomb. So in a sense, that was what 15 years earlier donors had been a little afraid of. But things changed reasonably rapidly after 2001. And in fact, one of the things that Kofi Annan, as Secretary General of the United Nations, called for as part of his re-election campaign for his second term in office was a global war chest, was what he called, which then became of $9 to $10 billion, which then became in part the Global Fund to fight HIV, TB and malaria. So the interesting thing here is to look at the trajectory of funding, and you can see that really it's the creation of the Global Fund and then PEPFAR, which is at that early point. So here's when the UN General Assembly Special Session is held. And this is an interesting little graph to look at, because it's actually, from that we can see the extent to which the United States has been clearly the major provider. This is just development assistance. This is all resources available in low and middle income countries. But in terms of development assistance, it certainly is the case that the pattern has been set by, and the majority of funding from the United States, and that's important to note. And this is from the new Miles to Go report that UNAIDS brought out in August, just last month. And this is another, and this is actually quite a nice way of presenting that escalation in funding available by looking at annual percentage changes in HIV resource availability. So that was what really started to change the prospects, including the prospects for providing treatment in a way that had just been unaffordable previously. So one of the things, the big thing that the money flow did, was open up the possibility of treatment access. It wasn't such a key barrier in relation to prevention efforts. Then the next thing I want to just reflect on briefly is President George W. Bush's announcement of the emergency plan for AIDS relief. And this is his State of the Union address in 2013. And this really did come as a surprise. There were some forces in the United States which had been pushing towards a much more extensive HIV response globally from the US, including people like Arch-Conservative Senator Jesse Helms, who'd been leading the fight against the evils of homosexuality in the US in the 70s and 80s, but who then, from the point of view of saying, the churches I'm involved with have parishioners, have congregations in Africa who are dying like flies, we have to have some moral response to this. And so that was part of the change in the trajectory. But really, so then this commitment of $10 billion in new money was a big surprise. It came as a big surprise. However, the thing we have to remember about this commitment is the fundamental driver of it was geopolitics. This was the nice side, this was the soft side of the war on terror and the Gulf Wars. And that's not a set of conspiracy theorising, arcane sort of argumentation, because here you go from this paragraph of Bush's State of the Union address to the very next paragraph. This nation can lead the world in sparing innocent people from a plague of nature, and this nation is leading the world in confronting and defeating the man-made evil of international terrorism. It's there as a very, very explicit and very clear commitment. So that's really, in some ways, the point I want to make about that. Now, I think, as I say, that investment in funding was responsible for this very substantial trajectory in terms of the increase of the number of people globally living with HIV accessing antiretroviral therapy, up to the 21.7 million people who access it at the end of 2017, according to the latest figures. So, I mean, I say some of this because this is a very substantial achievement. It's not to be sneezed at. It's a big change in the way in which global health and global health politics worked. As I say, the reasons for it are geostrategic as much as, if you like, compassionate. But it is nevertheless a big change that happened. I want actually now, though, so I want to note that, but leave the treatment story to some extent to the side now and turn rather more to the prevention story, which I think is interesting in a whole lot of different sorts of ways. So really, just to have a quick survey in relation to the prevention story, the first thing I want to note, and this is also from this most recent report from UNAIDS, the first thing I want to note is that a lot of the prevention story in the last decade has been misunderstood as a story of access to testing and treatment. That is clearly an empirical mistake. The evidence does not support that argument. And what I find interesting is that here, this comes in this latest report, and it's just typical of many of these arguments. This is a commonplace argument, which says that prevention efforts, harm reduction, needle and syringe exchange, and opioid substitution therapy have been things that have helped to prevent the HIV epidemic amongst injecting drug users, as has the increased access to treatment and testing. But if you look at this graph, it's a very nice illustration of the extent to which the epidemic came down before, this is this little blue dotted line, precisely before there was any substantial access to HIV treatment for people who inject drugs. And if you look at, Julio Montaner's figures from British Columbia in Canada, once again, the sort of same argument is made, and yet it is precisely this evidence which is used to say that access to testing and treatment was key in relation to curbing the epidemic amongst injecting drug users. And so, I use this just because it's a nice illustration of the extent to which, with the evidence staring you in the face, you still kind of get the interpretation wrong. And I do think one of the key things that has been gotten wrong is the fallacy in relation to HIV diagnostics. And that's not specific to HIV. It is often the case that diagnostics drive a notion of the question of the dynamics of an epidemic in a way that they shouldn't really. And for that reason, I, at the moment, don't really like even talking about HIV testing programs. I think it's much better to use the phrase diagnosis of HIV or HIV diagnostics, because that kind of puts it in its place, I think, a little more. And if you look at the empirical evidence, I think there's a strong argument for saying that one of the things that, for example, has confounded the results of what might otherwise have been successful HIV prevention efforts, including some trials in relation to HIV prevention, has been that their starting point has precisely been HIV testing. Now, if it is the case, and there is a body of evidence which suggests that in some fairly substantial way, although the dynamics are complicated, in some fairly substantial way, it certainly has been the case in the past, that HIV testing can actually increase risk behaviours, and the behaviour of test until you test positive is something which can be encouraged by testing programs. And if you look at the Uganda story, you can actually say that one of the things that led to the upturn in HIV incidence in Uganda was precisely the boost to funding that the United States government gave to the testing centres in Uganda. So actually testing itself as a technology, as a diagnostic technology, can get in the way of prevention efforts. And so I think what has been sort of, in a sense, understudied is the extent to which, in relation, for example, to some of the behavioural trials in relation to HIV prevention, that the testing requirements and parts of those trials might in fact have confounded the prevention results. And that's of course not something that people really want to hear very much. That's not something that really can be taken into account of. But I want really to go from here to look at if you look at the trajectory of HIV prevention efforts globally. This is from the Communications Framework for HIV/AIDS. Bunmi Makinwa was the lead author of it, a co-publication between UNAIDS and Penn State University. This I'm positing as perhaps the high point of what was at that point labelled social and behavioural change communication in relation to HIV. And this is the house-to-home diagram. And the argument that was being made in that report was that in fact, whilst you have the sort of structure of houses, people and cultures and complicated practices make those houses into homes, and we have to think about the framework of HIV and HIV prevention in that sort of context. And I think it's quite a powerful and quite a good metaphor to be used. So this, as I say, came out in 1999, and it had come from a long period of health promotion's initial response to HIV, then health and then prevention and indigenous prevention efforts in HIV-affected communities across the world, and quite a lot of effectiveness of that, and the complete failure of any availability of a medical curative sort of response. And so that was, in a sense, what people had to work with. And so that was this period from, as I say, about the end of the 90s through to about 2004, 2005 was probably the high point of these sorts of discussions. And what is interesting, and certainly Sue Kippax and Neve Stevenson's socialising the biomedical turn in HIV prevention is something that I sort of entirely endorse, I'm in furious agreement with, perhaps not surprisingly. Sue is my most important intellectual influence. I feel very much that I'm in enormous debt to her, and I kind of like to think, if I may, I like to think that there's a lineage from John Anderson and Andersonianism and a particular sort of Sydney pragmatic but rigorous style of thought that I'd like to think sort of flows through Sue and then has helped to inspire me. So I would just want to sort of note that at this point, if I may. But I think that Socialising the Biomedical Turn in HIV Prevention is a great book, and one of the things it does is it sorts out this question of, did Uganda believe in the ABCs, the abstain, be faithful, condomise? And of course that's not the case at all. And in fact it's probably the best and easiest way of checking whether someone knows what they're talking about or not. If they say Uganda had success in its HIV prevention response because of the ABCs, you immediately know that they're talking through their hat. Because that is simply not the case. Now, the ABCs probably in part come from Father Bernard Joannet and his Tanzanian abstinence, condom and fidelity 3 boats, and the idea was you jump into whichever boat is available as you navigate the tide. There is some evidence, which I think is probably true, that the first use of the phrase abstain, be faithful and condomise was by the Philippine Secretary of Health in the mid to late 1990s, and condomise was something he was very keen on saying, and he seems to have been the first populariser of that. Manto, the South African Minister of Health, then started adopting the phrase, but not till about 2001, when South Africa was also under tremendous pressure to start expanding a treatment program. And of course, it was a phrase that then was taken up by Edward Green and others in the context of a very specific culture wars argument about the role of Christians of a particular sort in programming for international assistance. So that in a sense is where the ABCs came from. And one of the reasons for sort of referring to that is because then sort of slightly displacing what had been, I would suggest, emerging and reasonably sophisticated and in a sense growing in sophistication arguments about HIV prevention, which were available on the global stage at the end of the 1990s. They were pushed out by an anodyne, incorrect and empirically badly based set of theories that promote the ABCs were one, but it seems to me also another was this type of campaign, this being one developed by FHI 360, and I don't want to sort of diss FHI 360, and there are certainly people, including people I know very well, who've done very good work with FHI 360, but there became a style of campaigning of which this was an example of, strategic behaviour communication, linking HIV prevention with a hip, fun and healthy lifestyle for Khmer men in Cambodia. So there was a very deliberate attempt to create a modern style of products, and it's interesting to, employs branding to motivate clients identifying with the products. So it is a very specific sort of language. And the take and the take up of these sorts of programs, it seems to me, was very variable. I remember, because it was a very striking experience, just making a very quick trip to Cambodia to see how some of these things were going. And two things were interesting, one of which was having a discussion with the head of the National AIDS Control Program in Cambodia and saying to him, was he troubled at all by the fact that one arm of the US government was doing this sort of thing and also doing outreaching with sex workers and looking, you know, in some with a degree of sophistication about the nature of sex work as it was unfolding in bars and bar girls of various sorts and beer girls in Cambodia, at precisely the same time that another arm of the US government had drafted and forced the Cambodian parliament to adopt a law demanding that all sex work establishments be shut down. And so, you know, was it troubling that these two things, obviously contradictory, were happening at the same time? And in a sense, you know, of course, you know, you can't ask these questions entirely, and you certainly can't expect to get clear answers. But the type of non-answer I got from him seemed very much to be, well, you know, who cares what the US do as long as some of the money trickles down to us? That was one thing. And then the second thing is, you know, while you have this sort of modern branding campaign, I also went to some work that was some outreach work to a sort of a little hall thing with an impromptu cinema set up. We're packed with about sort of 300 Cambodian men sort of sitting shoulder to shoulder, watching straight porn being broadcast on the screen and being aroused, and every so often someone would go off to the back of the hall, and there were these mainly fairly young men who would sort of pop into the toilets with them. And to the credit of FHI, part of their outreach program was indeed working in this sort of setting as well. But in a sense, I couldn't imagine anything further from these nice blue M-style T-shirts to sitting in this packed sort of little sort of hall with this very interesting and quite ambiguous sort of sexual practice going on. So I guess my point about some of this is it's not surprising that it missed its mark to some extent in terms of impact. Now, from here I want to go on to looking at some of the biomedical aspects of HIV prevention, particularly treatment as prevention, and also PrEP. So the first thing to note is, of course, that it's been quite a long time between the Swiss statement of 2008 and the U=U campaign. And I think it's interesting that these things sort of sometimes take quite a long time to come out. Now, of course, I assume everyone sort of pretty much knows the story of the Swiss statement. That's to say, a statement by the Swiss National AIDS Commission that the evidence from, you know, a detailed cohort study that they had been keeping track of really since the beginnings of the epidemic demonstrated really pretty conclusively that those with fully suppressed virus in the absence of in the absence of STIs did not need to use condoms, that was as safe as condom use. Now, one of the things I guess I want to make, one of the points I want to make about this is that there's a very strong contrast between the reception of the Swiss statement, and the Swiss statement ended up being endorsed, but with some qualifications and a lot of caution by the World Health Organization and UNAIDS, but it was nevertheless endorsed. But, you know, there had to be a very big sort of scientific meeting convened about that. I want to contrast the reception of that with HBT-N052 in August 2011, where, of course, it was sort of immediately, instantly, you know, 96% reduction in HIV transmission. Now, one of the arguments, and Sue and others make the argument that one of the differences between those two things was that HBT-N052 was a randomised controlled trial, and the Swiss, you know, equally good sort of evidentiary base, but not dealing with the very specific problem of selection bias and therefore the need to use randomisation as the most crude and readily available tool you have available to selection bias. So if you're lazy and you don't want to deal with knowing your study population in a great deal of detail, well then you'll adopt randomisation as your technique to overcome selection bias. So of course there is that difference that I think is in part the difference in the reception of the two pieces of information, which in terms of their consequences were essentially very similar. But the other difference that I want to sort of draw attention to is, it seems to me there was a very big difference between, on the one hand, the Swiss statement saying that discordant couples can choose to forego using condoms, and HPTN 052, which is, we will treat you as early as possible. The subject positions, the actor positions, are very different. And that, it seems to me, is really the principal part of the explanation of these two differences. That's to say, something that said that this is information that people can use as they construct their sexual practice, out of the control of the medical profession, was very different to something which was saying, this is a new treatment option which the doctors will treat you with. So that's just one thing I want to draw attention to there. Now I'm going a bit slowly, so I'm just going to whip through a few things. Firstly, in relation to PrEP. Of course there's been a long discussion in relation to PrEP and its efficacy. I think we're only now starting to have what is emerging as a sort of a suitably sophisticated understanding of PrEP and how it happens. Here's one of the slides Peter Piot used in his Amsterdam AIDS conference address a couple of months ago, where he actually contrasts what's happened in the city of San Francisco with Alameda County and the fact that new infections still continuing to rise in Alameda County, and in particular amongst African American young gay men. And so there are those differences which are very clear in relation to PrEP. Now, one little anecdote I want to add to that is, I recall when Bob Grant, the IPrEx chief investigator, first presented in the WHO building his results from IPrEx. One of the interesting little snippets of that was that amongst less educated gay men in Peru, PrEP didn't get to the 30% efficacy threshold that was the one that they were using in the study. Now later, that stratification disappeared from the analysis. Now it's perfectly possible, of course, this is not a question of, this is not someone hiding their rabbits. It's perfectly possible that the numbers just weren't there to power that sort of stratification of the sample. But nevertheless, for me, that is something that sort of put the radar up, I think, really right from the beginning of IPrEx, or the results of IPrEx, that you actually needed to think about the extent to which education and background in different contexts was having an impact on the efficacy. And of course, then the other thing is, for a long time there's been this period of saying, oh well, no, risk compensation doesn't apply to PrEP. But of course it's there, and there are people here who are saying that. There's this sort of nice Chicago paper from in Jades just recently, and Martin and others are bringing a much more, bringing the empirical evidence to bear. And this is, it seems to me, is not, no one should be surprised by this. The only thing people should be surprised by was that for a few years people were not picking up, especially in very managed cohorts in Africa, they were not picking up that sort of risk compensation. And I say that sort of reasonably carefully to sort of say that I actually think that people also have given insufficient credit to the extent to which research subjects know very well the answers they are meant to give to the surveys that they are administered when they're on trials like that. And certainly my experience of looking at a number of the participants in trials in Zimbabwe would suggest to me that actually you needed to think about very sophisticated consumers of medical trials as the participants in those trials. And then the other thing I just want to, I think it's really interesting to look at the gendered language in relation to, you know, hyper-gay, hyper-gay, proud, epic. These were the trials that were pushing the sort of wonderful response to PrEP. Now, it's kind of interesting to look at the female trial, dreams, hope, aspire. Now, I think there's a bit of a difference there. I don't know if you can detect a gender difference there, but I think I can. So it seems to me that that's quite important. And then just the last point on PrEP, and then I'll sort of try and really gallop through the last things. The last point on PrEP is that also, and this is a point that I first heard Marcia Rosengarten making, which I think is very interesting, and maybe it's a moment that has been and already gone, but in part of that slow burn and, you know, the way in which Gilead, which I'm one of those who is of the view that Gilead has never owned the patent for tenofovir, that they asserted that they would have a patent on tenofovir, which was actually something which had been developed in a Czech public health laboratory, that they asserted the patent. And, you know, as we know, China hasn't given them a patent. Their initial patent proposal to the US FDA, or US Patent Office rather, was denied, and it was only after appeal that they got it. But I don't think Gilead's ever actually owned that patent, but, you know, nevertheless, by asserting that patent, they've made billions out of it. But now, what was my point about tenofovir going to be? That's right. In that slow burn of PrEP, one of the things that made a difference was it actually created a heroic actor role for HIV-negative gay men, which had simply not existed before. So in a way, it was that role which was in the mid-80s, you know, when kind of we all didn't know our status was the sort of discourse in gay communities. Then, you know, both possibly infected, possibly not infected, were taking on that heroic actor role. Then that devolved, of course, to HIV positive people. And so in some ways it's been an attempt to sort of recuperate some of that role. So that role of I am the one demanding that HIV-negative gay men be able to have access to PrEP became something of that role in a very similar way. And I think that's a sort of plausible argument. So kind of we've gone from this to really sort of the end of AIDS, getting to zero. I can tell you about where these things came from in some detail if you're interested in questions in terms of the, you know, who first suggested the zero. You know, this was actually about, this Economist cover was about the HIV investment framework, which doesn't use the phrase getting to zero, or actually I don't think it uses the end of AIDS, but that was the way in which the Economist took it. So the AIDS crisis, this is from 1988. There is the trope of AIDS is not over yet is a long one. So to me, it is not surprising at all at the moment that there's a very contested notion around the end of AIDS. So what are the roads not taken? So I just want to kind of quickly run through a few things. So one is, which is serosorting, and I'm partly just showing up this poster. One of us has HIV, two of us have sex. This comes from 1992, developed by Bill Hathaway, the HIV positive education officer at the Victorian AIDS Council. And this, in a sense, was part of that moment of sort of saying, positive or negative, it doesn't matter. You still behave in the same way, so you still use condoms. But the explicit use of that in relation to people with HIV was very unusual and quite contested. It was one of the reasons why, when he was Health Minister, Senator Graham Richardson got extremely cross with the Australian Federation of AIDS Organisations for its cover where sort of Brown and Carrigan were enacting sex as sort of bodies with AIDS enacting sex, and Richardson said, this is an outrage. How can you possibly use this sort of imagery in the context of otherwise having been very supportive of community responses to HIV? So it was interesting that was some of the boundaries of that. So I do think that serosorting, the question of using serosorting seriously, of course, to some extent dealt with in the negotiated safety campaign, but it is striking the extent to which it has not been taken up. I remember going to a quite crucial meeting in the end of the 2000s where Steph Bertozzi, amongst other people, he was then still at the Gates Foundation, was suggesting that this was one of the big neglected bits of the HIV prevention response. But it never got taken up. Second thing I would just want to alert to is once again something which I think there's this really interesting paper, which is one of the last papers by Everett Rogers before he died with colleagues, about complex adaptive systems and the diffusion of innovations. One of the really interesting things about this is it suggests the structural properties of adaptation in complex systems are exactly the same structural properties which predict diffusion of innovation. And it's one of the reasons why you have very rapid community responses amongst marginalised communities, because the things which are connecting those communities in their marginalisation are precisely the things which are then diffusing innovation. And I think that's a really important insight which could have been used but hasn't been in HIV responses. That then leads to the whole field of behavioural economics, the whole nudge, the whole UK Cabinet Office in relation to nudge, the whole area of which it seems to me has added to understandings of adaptation. Sort of behavioural economics and co-creation, etc., etc. Now, some of those are very subtle changes which can be made. So I saw a recent report from the Behavioural Insights team talking about the difference between having a red and a green marker in your doctor's appointment alert app, and how much of a difference that made. And some of this argumentation is about very micro differences that can have very major changes and impacts on the way in which programs are rolled out. In terms of the global health landscape, I think there's attention to be paid to the whole question of quality. This goes to the AIDS out of isolation discussion, where qualities, it seems to me, very important. And precision public health is clearly a very important debate, but let's note as well that there's now a bit of a backlash, and a good backlash, against some of the assumptions about big data and targeting, and the argument of Ron Bayer and colleagues is that precision public health is in fact trying to draw public health back to individual rather than collective outcomes, and that's bad. Now, I think that's a big debate, but I think it's a very important and useful one. And lastly, I guess, prevention cascades, where it seems to me once again this is an interesting approach that, and we work with Tim Hallett on the HIV investment framework, who was at that point trying to say, well, what evidence can we have about the sequencing of different prevention programs, which might say that if you do one before the other, it may have more impact than another. And that then has since been developed a bit into these prevention cascades. And really just the thing to note about these is that it's starting to be, I think, a different set of argument, which actually gets away from, and as Neve and Sue have said, I think very clearly and convincingly, the behavioural, biomedical, structural are the things you do in prevent. That's a division which doesn't work. It's not useful. It's theoretically inept. It's not adequate. Whereas these prevention cascades, I think, from a language which is actually being driven more than anything else by modelers. And that's an interesting thing to note. It is the modelers that are driving this discussion. The modelers are actually coming to a point where they're actually sort of saying, let's look at population level constraints to translating the efficacy of direct mechanisms. And so that's starting to be a language which I think is much more effective. And I can talk a little bit about circumcision later if you want to, and just really to say that I'm now working on posthuman bioethics, the convergence of one, health concerns, human, planet, animal, with artificial intelligences, and from a Spinozist philosophical point of view. But so really I want to say that the global consensus which has emerged at biomedicine plus a smattering of mainly rhetorical human rights is a much less adequate response than technologically mediated social change. The work that then is required is complex. It's not simple and straightforward. It's less easy to sell to funders, etc. And I also want to say that in particular in relation to, and there's a whole argument I would also sort of like to want to be a bit cautious about looking at the way in which, for example, homonationalism has been part of a hegemonic way of asserting particular views about, for example, in relation, I mean, the homonationalism refers to that in relation to gay identities around the world. There is a certain sameness in terms of the hegemonic picture which is provided by some of the global AIDS and health effort, which I think also requires a great deal of caution. Thank you. You can use a false identifier, like with early HIV testing. Minnie Mouse. Minnie Mouse now wishes to ask a question.
That was more for Michael, because he doesn't know you. Yeah. Hello, Michael. You mentioned that you'd talk more about circumcision, and so as no one else asked a question, would you like to?
Okay, well, I think one of the things, and you know, even to also make this point about circumcision, that it sort of depends. Now, I think grassroots soccer in Zimbabwe, it's something which arose in Bulawayo in Zimbabwe, is a very good example of a programmatic response to HIV based around the desire of both girls and boys in the local community to play football and to be given some footballing skills. Now, I think one of the there's two things I want to, and they have used that reasonably successfully in terms of promoting, in promoting male circumcision. Now, there's a couple of things about that I want to mention. One of which is talking with Ntembe Ndlovu, who's the key sort of football player, person who runs the program. Having a conversation with him about the importance or otherwise of circumcision to Ndebele men, so it's important that it's Ndebele and not Shona men in this area of Zimbabwe, he suggested that they are relatively indifferent to being circumcised or not. They know that in the way long past they were circumcised, circumcision has sort of dropped out, but it's not something that has particular concerns attached to it. Now, my point about that is that varies, of course, you know, in every community, and it's actually quite difficult for kind of the funders and health actors to have those sorts of real conversations about what's really going on in a community to actually see whether there is the basis or not for being able to support men's sort of reasonable desire to become circumcised. So I think that's one thing. Although it's also interesting that there is certainly a dynamic, and that circumcision, or the male circumcision program as it's been rolled out in Zimbabwe, has principally been amongst very young boys, well, you know, young boys 8 to 12, often sent by their mothers, so mothers approve of it, or faking their consent forms. And, you know, the people who run the program know that these, you know, the boys come in and they sign each other's consent forms. Okay, fine, whatever. It's a program, we have a quota to meet because the US government is funding us to do this. And the doctors are doing the circumcisions because they get, you know, $15 per circumcision performed as a sort of an extra allowance on top of their salary, etc., etc. So it's been quite important. So a whole cohort of doctors in Zimbabwe have supplemented in a major way their income by providing circumcision. But the other thing is that one of their programs that they did was actually with the coaches of these soccer players, getting them together in bars to talk about how they would be sort of positive role models. And I actually think, really interestingly, that may be the most crucial part of the impact of their program. But it's not actually really what is talked about. So the fact that these 20-year-old male role models, in a context where there's not much other employment in that area of Bulawayo, the fact that they're getting together and being supported to run this program and talking about it, that may be the thing which is actually having the key impact on not only circumcision outcomes, but actually on health outcomes more generally, because it's creating a certain, I mean, it's a type of bowling together that is being supported. So I think it's also interesting that programs often don't recognise themselves where their major impact may be coming from.
Thanks, Michael. Martin Holt from the Centre for Social Research and Health. That actually leads really nicely. I liked your overall thing at the end about technologically mediated social change, but the question for me is whether that is done in a public health implementation science discourse or if it's done sociologically, because I think some of the fantasy in all the rhetoric around precision medicine and fixing programs is what people are looking for in program management from a public health top-down view is something easy to fix in a system, whereas if you occupy the sociologically mediated space on technological social change, you know you actually need to look at the grassroots things that actually matter to the people involved. It's weird that 30-odd years into the epidemic, that truism that people ignore what matters to people on the ground is just reproduced in whatever vogue there is in planning, modelling, program change. So that to me is one of the critical things where I think the fight over who gets to be in the room or who gets to write or influence implementation science, whatever that is, being another Sue disciple going, don't know what that is, but anyway, but I mean, one of the strategies at the moment is to just insert yourself into that space and say, well, these are the things I think that we should be looking at. I had some other comments about serious sorting and and actually, no, a really good example is U equals U. So I have a slightly different take on that because I was looking at that Venatza actually was once he was heavily criticised when they put out the Swiss statement. He was in his defence at the time was that his advice was for doctors, it wasn't for patients. It was about how doctors manage serodiscordant couples. It was incredibly paternalistic, his initial defence. And then, of course, he's crowing because, of course, he's been sort of proven right. But my main issue now globally is U equals U, the triumphalism at the moment around the scientific evidence, particularly in Amsterdam, say most recently, does not extend to the bulk of people living with HIV who do not have the conditions under which they could be reassured or take any comfort from U equals U because they don't have access to viral load testing, don't have stable access to treatment. And I actually think the movement is, when you're talking about high income countries versus low, there's there's a huge gap that follows after that. Where we can kind of sit here and go, most positive people we know in Australia can have access to that, but most people in far-flung regions of sub-Saharan Africa cannot and don't even know anything about it.
Yeah, I mean, firstly on implementation science, I'm not as worried about that phrase. I actually think it creates space, and I suppose partly that's my argument about the prevention cascade stuff that the modelers are all over. I mean, it seems to me it necessarily starts opening up that space in a more sophisticated way, and therefore, if that's the opening that's available, okay, take it. So I think it has more positives than negatives. Although then partly because it actually then results in being able to say, well, what is that science of which you speak? And that's actually, there should be an answer to that. And if there's not, you should be saying, well, okay, here's some science for you. So but then on the, in terms of the Swiss statement and the paternalistic, I mean, I actually think that that was the reaction that was forced in a sense. So, and it was partly because, you know, Swiss doctors are very nice people who have very nice relationships with their patients, and you know, I mean, you know, I'm not being sarcastic about that. I mean, I think that there is a very solid notion of therapeutic partnership that kind of is part of that practice, and so then when being sort of pushed into it, and how can you be, and you know, I mean, I had sort of screaming matches with colleagues in UNAIDS who would basically say, how can you, this information, those people out there just can't handle this information. You know, you can't handle the truth. I mean, you know, and it was kind of, and that was, so I'm not surprised that that was sort of how the defence happened. I do think that that's more the reaction to it than, although, I mean, if you actually look at the statement, yes, it very much says that, you know, in the context of the clinical practice and your 3 months checkup, etc., then you can. Now, in terms of U equals U, I'm not sure I agree entirely. When I was in Zimbabwe as UNAIDS country director, basically almost every speaking opportunity I got, and there were lots of them, I would say to people, now, of course, it's very important that as many people as possible get on treatment, you know, provided publicly and you know, reasonable conditions of access, because then, you know, you don't have to use condoms, whether for pleasure or when you're going to conceive a child, and this is really important. Now, this wasn't part of, this wasn't what the National AIDS campaign was saying. This wasn't really what was said by the authorities. I thought it was a very important part of people sort of seizing control of the treatment rollout agenda. And also, I think from a public health point of view, to drive treatment take-up through imperfect treatment access, I think is worthwhile in terms of its impacts on health, and probably including on HIV transmission. I think you would have to have a lot of mistaken. You would have to have more treatment failure than there is for the balance to tip over into not saying it's worthwhile to say that to people. Now, you know, that maybe works in Zimbabwe in a way that maybe it doesn't work in some states of Nigeria, I'm not sure. So I think it has to be looked at very carefully. But in a general sense, I would actually say that it's worthwhile talking with people about treatment take-up for those sorts of reasons.
I know I was agreeing. I was more that the reassurance that there has been seized, I'm not, you know, I think it's imperfectly available, and so one of the things in Amsterdam, quizzing people involved in the U equals U movement is saying, so now what's your next step to make sure more positive people and their partners can be reassured by this message? Wasn't actually a great deal of answer on that.
Right.
Having got IS and everyone else to agree to the message, so that.
I have actually been, well, I don't know, I've been slightly mystified by the sloganeering around U equals U. I don't understand what the great additional benefit of a slogan like that is. I don't understand why people are saying this is game changing. It doesn't, it seems to me it's not but yes, so I think the sloganeering is not entirely useful. Also, of course, I think it's also associated with magical thinking, which of course I think is also one of the main things which is happening in PrEP. So, you know, obviously there is magical thinking with PrEP. You say, I'm on PrEP, of course I'm on PrEP. Yes, of course we don't need to use a condom or what, you know. Or it's not even used as, I mean, you know, it's used in sexual encounters as just the signal. PrEP. You say PrEP, and then you can, you know, go at it like bunnies, and that's fine.
or how have you
I mean, I think a very complex picture. When I was in Guatemala, there were a number of, in particular, that's an epidemic which has two parts to it, one of which is amongst indigenous people, because 50% of the Guatemalan population is indigenous Mayan, 50% is of sort of Spanish origin and mixed, and in the non-Indigenous population, it's an epidemic driven principally amongst gay men. Many of those activists identified the Catholic Church as the key enemy. I thought that was tactically probably a mistake, but that was part of sort of how that dynamic was going. In Zimbabwe, there is this enormous proliferation of very informal apostolic churches, so what are called the sort of white angels, so groups with and there are pastors in Zimbabwe who can attract crowds of 1 million people, and at least Sunday, but on many days you see large groups of people gathering in the fields in white robes, praying and being lectured to and harangued by a pastor. One of the most interesting projects we did in Zimbabwe was to work with. These are not organised churches. There is an association which tries to work with them. We had, it was called Stories of Shattered Hope, because a really strong tendency of these pastors to say, you must stop your antiretrovirals, God will protect you. And a lot of women, like a significant proportion of women who felt they were forced off antiretrovirals because their church was telling them they couldn't. I went into a health clinic doing this sort of amazing stuff in the sort of right near the border with Mozambique. I kind of made this visit to the clinic and they were doing all sorts of HIV testing. They had a PEMA point of care CD4 machine blinking away in the corner in a clinic where no one had provided them with any money to be able to make a call to the local hospital. So, that was the kind of difference in the resource constraints, and it was quite interesting. They said that women in that area have to come to that they run their prenatal classes after dark because they would be beaten up otherwise, because you are going to the medicine thing as opposed to God looking after you. So it's a real, so that's a real issue. Zambia has actually made it illegal for preachers to say you should go off antiretrovirals, and they've actually done some prosecutions. So how that then relates to, I think there's a much more complex discussion in relation to sexual practice and what's expected sexual practice, which is partly to do with, the incorporation of the relationship between colonialism, sexuality, and independence is a very and religion is a very complex one that isn't able to necessarily be read very easily. By and large, in Zimbabwe, my experience was it was always useful to find some religious reference points. So as someone who's, so actually sort of quoting a little bit of verse or whatever is always, biblical verse is always a good way of just connecting with a crowd, or connecting with a crowd, whether it's a crowd of, people in a suburb or of, the leading country's leading scientists sort of thing. So the presence of religion in that sense is sort of is very close there. Is that an area that you work on, or?
Yeah, thank you very much.
Right.
I think we do have to wrap up. We've gone over time. Please join me in thanking Michael.